Thanks, Dr. Brian. It's my great pleasure to lead the two sessions in the morning. And our guest speakers is Dr. Elimika Fletcher from FDA. Dr. Fletcher is the policy lead in the Office of Clinical Pharmacology. And she holds a Doctor of Pharmacy and a PhD in Pharmaceutical Sciences from University of Houston College of Pharmacy. She previously served as a Senior Clinical Pharmacology Reviewer supporting oncology drug product from 2009 to 2016. Please welcome her, and the microphone is yours.
Thank you. I will
Dr. Elimika, do you hear us? Elimika? Yeah.
Yes, I do. I just share my screen if I can go ahead and do that.
Yeah, we are seeing your screen now. Yeah, you are loud. Okay, you can do that now.
Can you see my correct screen?
Yeah, but presentation mode.
Oh, you can see the presentation mode.
He has.
Now, can you see my screen okay?
Elimika, if you go to share screen at the top, there's display settings, and then you can swap display. So first go to share screen, the share screen button, and then you should have a view options.
For some reason, let me just get out of here.
Slideshow. Go to slideshow. On in your PowerPoint, just go to slideshow. No, in PowerPoint, go to slideshow. Okay.
For some.
Okay. What's that? No. Okay. So go to if you go to slideshow in PowerPoint. So if you go to on the top of the PowerPoint, you'll see the slideshow option. Yeah, and she's muted.
Is it still just showing my display mode?
Yeah, yeah. We don't see the slideshow. We see your slide and your PowerPoint screen.
Okay.
You do share screen, PowerPoint, and then go to.
Huh. Is it just still showing my screen?
It's showing. So
I'm not sure. When we were in practice mode, I was able to share it. Okay.
It always works in practice mode, right? So if you pull up so we see your image and our image, whichever. So if you go to PowerPoint, okay.
Okay, let's try this.
There we go. Share. And there we go. Perfect.
Wait, just give me a second. It's not showing on my end for some reason.
Zoom just covering the slideshow, maybe. We were seeing it.
Let's see. Okay, do you still see it or not?
Oh, we don't see your screen now. Have to go back and share screen again.
That is just hilarious. It's almost like a completely different thing than when we were in presenter mode.
Yeah, so we see your PowerPoint, so just try the slideshow and see if that works.
Now, does it work?
Then at the top, go to display settings. There.
Okay, so what do you see on there?
Swap. Yeah, perfect.
Perfect.
Okay, perfect. All right, so you see my slideshow now?
Yes.
All right, perfect. All right. Sorry about that. Good morning. It's such a pleasure to join you today. It's been a really nice conference so far. I wish I was in person listening to all the background conversation from everybody. I'm really excited to start off the day discussing lactation. It's a topic I'm very passionate about and excited to see the advancement in. As mentioned, I'm a policy lead in the Office of Clinical Pharmacology, and my main areas of focus are pediatrics and maternal pharmacology. The views that I'm presenting today are my own and should not be interpreted as the position of the FDA. Are we still good?
Yes, we are still good. Everything looks great.
Okay, perfect. Thanks, Sarah. Well, personally, I've developed a passion in this area as I've personally been pregnant or breastfeeding my last 9 years. So 3 kids later, I think I'm at the end of that journey personally, but still realize that many others are impacted by this topic. We see that 1 in 4 mothers are reported to take medications during pregnancy or and breastfeeding, with less than 5% of drugs with actual human lactation data, sadly. In this paper that I worked with some academic colleagues on, we identified that for new molecular entities approved between 2001 and 2020, with recommendations in labeling either stating a drug is harmful or should consider benefit risk or is safe to use, most of the data was actually based on animal studies, and consistent with what's been published, we found that only 5% of these drugs actually had human lactation data. So giving us some hope is that the number of post-marketing requirements and commitments related to pregnancy and lactation are increasing. So we are asking for more studies. These are not all related to disposition in terms of pregnancy PK or lactation, and really a small portion of them are. When we specifically look at lactation studies, that's lactation exposure data, we see that there is an increase in the number of lactation studies. However, this isn't a poster we published in ASCPT last year, but what we see is it's still a really small percentage of the new molecular entities that are getting post-marketing requirements for lactation studies. So hopefully we will get more lactation data, but this is a slow increase still. Our requirements in terms of labeling state that the risk summary section of labeling related to lactation should summarize information on the presence of a drug in human milk. And if a drug is present in human milk, the label must include concentrations in milk, the actual and estimated infant daily dose, and a comparison to the approved pediatric and maternal dose. So really understanding drug exposure in milk is important to inform recommendations and management strategies. But how does one translate how much concentration is in human milk into understanding the risk to an infant? So one common paradigm based on I believe it's a 1980s publication, is that drugs with a relative infant dose less than 10% are safe, 10 to 25% should be used with caution, and greater than 25% are unlikely safe. There really a single number doesn't really account for different therapeutic windows. If you have the same relative infant dose for fentanyl versus acetaminophen, no one would argue that you probably would think of those two quite differently. In addition, a single RID number may not reflect risk assessment across a relevant breastfeeding age range from 0 to potentially 2 years old, and that's supported by a literature review on serious acute adverse drug reactions in infants from drugs in breast milk that reported that 79% of reported reactions generally occur in those first 2 months of life. So when we were thinking about this, we were thinking that there is a potential to really incorporate clinical pharmacology knowledge and modeling and simulation to further inform the translation of exposure data and lactation into a risk assessment for infants. Potentially, modeling and simulation could inform before lactation studies performed to inform the likelihood and extent of exposure in human milk, and also help inform study design, including when would be optimal to get samples. After lactation studies performed, you could use modeling and simulation to assess the impact of pediatric and maternal covariates, such as pediatric age or drug-drug interactions and pharmacogenomic effects on maternal PK. It can also be used to inform mitigation strategies. But how often are we seeing PBPK in actual submissions? So this publication out of the FDA showed that in 2018, 2019, PBPK submissions to US FDA to support new molecular entities. And nicely, we see about 9% of them are pediatric, which can be used to support some of our lactation modeling. However, none was specifically related to pregnancy or lactation. So we are not seeing the translation of this yet in submissions. Maternal PBPK can address both prenatal exposure, which includes pregnancy PK and placental transfer of fetal exposure. And these can persist after birth in the infant and affect how much drug is in the infant, whether or not they're receiving human milk. And postnatal modeling can address the exposure in milk and the exposure in infants. I performed a crude PubMed search, and it really shows that the number of pregnancy PBPK models in publication are increasing. And so that is very exciting to see in the pregnancy PBPK space. And this is consistent with this recent publication that I saw showing that publications in pregnancy PBPK are increasing with up to 75 compounds in 2022. This pregnancy PBPK model examples that I found, excuse me, I have a cold, really address not only maternal PK, but also fetal exposure as well. They evaluate impact of relevant disease states, and in some cases, look at both pregnancy and lactation. Although far fewer than in the pregnancy space, a crude PubMed search shows that even publications related to lactation PBPK are increasing. However, when looking through the examples, one striking thing is that there's sort of lack of standard terminology of what you might expect that a lactation PBPK modeling might be addressing. So some address how much actual exposure will be found in human milk, while others are really pediatric PBPK models that explore how much drug via breast milk as an input and how that affects infant exposure. I include several examples here looking at predictions in an infant for various drugs, including one on sotalol that I was a PI for and will discuss in greater detail in a few slides. However, some lactation models are focused on predicting the amount of drug distributed into milk. There's one related to this conception trial that actually includes 10 drugs, and they developed a generic workflow that they published. Another one that looks at BCRP substrates, and another one that looked at basic drugs. Some PBPK models address multiple applications, which in some cases did not have clinical lactation data, but after modeling pregnancy PBPK, they added the lactation data component. In addition, some models include an integrated maternal and infant model that may address different maternal conditions and predict resulting infant dosage. I'll discuss a soon-to-be published example that we built for pregabalin that could be considered an integrated model. You will hear a little more about integrated maternal fetal model on the left in some detail in a later talk today. And on the right, you see a schematic of a model that addresses pregnancy PK, fetal exposure, exposure in breast milk, and resulting exposure in the neonate. One might also imagine that you could use this model with an arrow from the pregnancy PK to the neonate to address drug from fetal exposure versus breastfeeding across age range. So these models can be very complex or very simple, and a lot of different approaches have been used in the published models. We received some funding to evaluate lactation models. This is a project we have with University of Florida, Dr. Schmidt, and we wanted to see if we can integrate pediatric clinical pharmacology knowledge and modeling and simulation to better inform how we're looking at lactation data. So first, we identified and evaluated labeling with quantitative lactation data. And we looked at those labels to determine how lactation data and available pediatric clinical pharmacology data was used to inform the risk summary section of labeling. Then we selected some of those drugs to build a PBPK model to predict PK in plasma in the breastfeeding infant, to pilot the utility of PBPK to inform risk assessment across pediatric age range. So not surprisingly, we consistently found that most of the drug labels have no human lactation data. And of those with human lactation data, only a small number actually have quantitative information. The ones with quantitative information were about 120 products with 62 unique molecular entities. Most of the data that was in the labels was based on FDA review of literature and other sources. So pediatric information was found in the labeling of 34 of these 62, with only 6 of those with pediatric data in less than 2 years of age. So when moving on to PBPK, we looked at the initial list of drugs. We considered drugs with a significant amount of drug in breast milk. We used a cutoff of 1.9, and then we looked for those that have oral administration routes, so they are relevant for our breastfeeding model. And we started out with 2 renally eliminated drugs that I will discuss today, sotalol and pregabalin. So this is the model development workflow that we included in a publication by Michelle Presley. She was an ORISE fellow that worked on this project and has now transitioned to staff at the FDA. So first we developed an adult IV oral model, and then we scaled that to pediatrics and evaluated the model performance using pediatric data that we had available for those under 2 years of age. The model was then used to simulate pediatric exposure from drugs in human milk. The model used drug input from human milk, and Michelle evaluated several assumptions in describing the oral input for drugs. So because lactation data is limited, she used the mean drug concentrations from the study as a drug input. She also evaluated various maternal doses and other potential sources of variability, such as the number of feeds, the size of the infant, the age, and the sex of the infant. And we also used a publication from Yang et al. To inform the milk intake for the model. She incorporated the growth of the infant, and this was developed and calibrated to the mean infant size in the CDC growth charts. So just a high-level summary of what was reported in the manuscript is that so gender and different feeding frequencies did not seem to have an impact in the simulations. But she identified that infants in the 90th percentile in height and weight had predicted exposures 20% higher than infants of the same age in the 10th percentile. And that was likely due to increase in milk intake, since those individuals were the same age and we didn't expect that the clearance would be different. The simulation suggested that infants would have exposures within the lower range of the therapeutic drug exposure in infants taking the drug for therapeutic purposes. So this is, the green line shows single data from single dose studies, and the orange line is the lower end from multiple dose studies. This is consistent from observed lactating infants, for which we observed, which there reports that infants had bradycardia. However, we didn't perform PK/PD analyses to understand the relationship further, but keeping in mind that these breastfeeding infants are not taking the drug for therapeutic purposes. For the youngest age group from birth, the exposures on the first day were lower, but they increased significantly. And this is likely driven by lower milk intake at the beginning, and then the exposures increasing. This simulation was done over a 2-week period. We applied the same approach to pregabalin, which is also predominantly renally eliminated. And both of these used open software. So the big difference with the pregabalin is we used an integrated approach. So the adult oral model was used to build a female model, and a generic workflow was used to predict maternal plasma and human milk exposures. In addition, the adult model was informed the pediatric oral model, and that was used to evaluate the infant drug exposure. So the model performed well when looking at clinical data for single and multiple dose. So first we looked at the adult PBPK model, and it had a good fit for maternal plasma. And that was used then to simulate the breast milk exposure and the resulting plasma exposure in the infant. And that was applied to really look at what exposures would you see across the infant age range. And a similar approach was used to look at the infant exposure as was applied in the sotalol example. Similar to sotalol, the concentrations were on the lower end and within, sorry about that, the 2-week simulations had a consistent trend with sotalol. The youngest started at lower concentrations, likely due to the milk intake, and became higher over the days compared to the older age. The concentrations were lower than Cmax, but were within the C trough seen for therapeutic doses in pediatrics. So overall, in this case, we developed and assessed an approach to develop pediatric models using input from human milk instead of a pediatric formulation. We evaluated factors that could potentially impact human milk consumption across various infant age ranges. And these models did not account for differences in PK across postpartum period because there was a lack of sufficient data to validate that, because most of lactation studies include people across the postpartum period and don't have enough detailed information. So we considered the postpartum period as a single period. But integrated models like we showed for the pregabalin can allow for the evaluation of various maternal characteristics, such as different doses and pharmacogenomics or other aspects. We are currently evaluating how well lactation models can be used to predict exposures in human milk. And we feel that this would better inform the integrated models that we were just discussing. Considering we have an increased experience in pediatric PBPK modeling, we feel like those integrated models can do really well if we can make sure that our current models can perform well in predicting how much drug is in human milk. So the approach we're using is we build an adult model and simulate for the relevant maternal age group. So based on the lactation studies, sometimes we have females between about 20 to 40, and that's the age range we use in the model. And then we use that to simulate maternal plasma and human milk and compare it to available data in the lactation. So the first drug we looked at this is alprazolam. The model adequately predicted adult healthy data published, but seemed to slightly underpredict the maternal plasma, but even to a greater extent, the human milk data. Reading through the publication, we identified an actual reported value for the skim to whole milk ratio and used that instead of the model predicted skim to whole milk ratio. And we found that once we did that, the concentrations were within twofold of the exposure. We found that quite interesting, as this is not a parameter that's consistently reported for publications with lactation data, although it has been proposed in literature to be an important factor in influencing the transfer of a drug into human milk. So the skim to whole milk ratio is one factor that we've been looking at closer. The next drug we looked at was atenolol. We evaluated atenolol because it has there's a very interesting publication that reported data across different postpartum periods. We rarely have this in a lot of our publications. So they had individuals that they followed through and had data at 2 to 4 weeks postpartum, and 3 to 4 months, and 6 to 8 months postpartum. Also, because atenolol is dose adjusted according to effect, and for other reasons, what we saw is patients at 2 to 4 weeks had higher average doses than patients at the later time points. So this was a really interesting paper that addressed milk and plasma levels at different times postpartum, and we're evaluating the model across the postpartum periods. So this is just one time point, and it fit reasonably well and was consistent across different times. We had some challenges incorporating data from a titrated dosing scheme when the publications only reported average data, and are working to get additional information from the authors to really better inform the assumptions that we're making for this model. Some of this work is continuing. The next stage that we're looking at is really looking at drugs that are substrates of PGP and BCRP, because we started the work on drugs that were reported to not be substrates of these two transporters that are reported to be important in mammary tissues. But looking across models in the literature and also the work we've been doing, there's definitely opportunity to better define and look through best practices for lactation modeling that we can all agree on. There is a potential to apply these models further to drugs that are substrates of transporters. Majority of the drugs that are published in literature are not substrates of these transporters. So evaluation of these models across different drug products will be very important to see how well they can perform. And really, we do need an improved understanding of various transporters in mammary tissues. And hopefully we can see more work and publications in that space to better inform our models. With that, before we move to questions and discussion, I'm really excited about the growth in this area and really the increasing interest. I do want to acknowledge the modelers, the clinicians, and other collaborators, and really especially the fellows that worked on some of the modeling that we've done, Michelle, Cameron, and Rahul. And we're extremely passionate about this topic, and I'm interested to have discussion on this topic, especially around how we can maybe move towards more best practices in this lactation modeling space and how we can continue to advance the area. Thank you.
Thank you so much. We are open for any questions. Please raise your hand.
Could you explain a little bit more about the difference between skim milk and not skim milk, whole milk and breast milk?
Yeah, so that is measured, I believe, in vitro. Before we worked on that model, I'd seen it in some of some publications on IVE, in vitro, in vivo correlations that they measure sort of how much drug is in skim milk versus whole milk and report that ratio. And in a lot of those IVC models, it's been reported to be sort of an important measure, or important in figuring out how much drug will end up in the milk. And the models, including I think for the second project we've been using SimSip, it actually has a model predicted SW when you're looking, and so it's one of the factors that is used to predict how much drug ends up in breast milk. So it just happened in that publication, they had measured it and reported it. And so the predictive value in the model was much lower than what the actual value reported.
Hi, Elimika, this is Stefan. Nice talk.
Stefan.
So maybe to add to that comment, so my understanding is that breast milk is not equals breast milk. So the composition basically changes over the course of the feeding. So typically you first get like more, calorie-rich content in first, because that's basically what feeds the baby, and then it basically dilutes down as the baby keeps feeding to keep basically water content up, and so basically to quench the thirst of the baby. So and then obviously if you have a more lipophilic or protein-rich component of the milk first, then based on the on the physical chemical properties of the drug, then the exposure changes, and so feeding time will make a difference.
Any question? Yeah.
I actually go to Stefan and not Elimika. Did you account for changes with colostrum in these models at all? And it's just considered mature milk and how you want-
No. So one of the biggest challenges is just what information is in the publications. So some of the publications have mostly patients after 6 weeks. I think if we ended up looking at a drug that's used immediately postpartum, like maybe pain medications, you may have some colostrum information, but that is sort of really important in that, I guess, initial neonatal period. Unfortunately, we actually don't have the data to see what the actual differences are, at least not for the drugs we've modeled. But that would definitely be a consideration when you look at drugs that maybe are used in the postpartum period and maybe have more data, like in the immediate postpartum, and have more data in that realm. But that is a very interesting comment.
Thanks. It makes me question a little bit too, from like the Cuddle study and some of the other studies that are ongoing. And I don't know, Kosh, if you have experience, if they record the early postpartum versus what's later, and if you guys are seeing differences there.
So we are trying to record that on the basis of like when the baby was born and following that. But what we are seeing initially is collecting breast milk during the early birth stages is very difficult. So very few samples. So not to make enough scientific conclusion, but we have another study where we are evaluating if there is a difference in collecting breast milk at home versus at the hospital to see if there is any difference. So that's probably, we are waiting for more data on that to see if there is any difference, and that will increase the number of samples we get. But to answer your question, at this moment, we don't have enough data to make any conclusion. But again, coming back to the skim versus, that's something based on fat content and, protein content, we are temporarily following that in the models.
Thanks, Sarah, for
Okay.
bringing that in, Ashok. One aspect is when we're looking at sort of publications, sometimes we're like, well, I wish this was reported, I wish this was reported. When we're talking about best practices, some of these aspects, it would be good to sort of also have the discussion around what are the important aspects that we need for modeling, and what are aspects that we want people to report in their publications so that we can best inform our models. So
Yeah, and I know, from my work and trying to find the data on basically what is colostrum compared to mature milk, there's just not data out there. And I think probably because of the collection issue, it's very difficult. We're lucky to get a drop,
Any other question? If that, we thank you so much, Dr. Fletcher, and looking forward to see you next year. Hopefully, yeah. Yeah, thank you.
Yeah.